Yeah,
Hi, Baru. Can you enable mine as well?
sure. Yeah, I'm enabling that. It's enabled actually. Now you should be able to turn on your videos.
Same with mine, bro, if it's not too much trouble. Hi,
Okay.
Sven. Hi, everyone.
Yep. All right. So participants start joining. I think let's give them
Hi, Guru.
2 to
Sorry,
3
can you
minutes
enable
to
my
join.
video as well?
Okay.
Hi.
Okay, sure.
Yeah. So Dr. Abnett, do you want to start or do you want me to lead off? How should we do this?
I think I'm going to introduce you, Svea,
Okay, great.
with you,
Guru,
and then
sorry.
we can get on from there. Yeah.
Okay, sounds good. Oh, I see that. I just saw the schedule. I should have read before I ask questions.
No, it's fine.
Guru, sorry, can you enable my video as well?
Sure. Yeah. I'm enabling it now.
Okay.
We have two Mukherjees on the panel. That
Yes,
does
I
not
know.
happen.
We kept getting confused in the organization because we kept being like Dr. Mukherjee, and it was like,
Yeah.
wait, we'd be writing about the wrong one. We got very confused.
Yeah, and in the world of Mukherjees, these are very similarly spelled Mukherjees.
Yes, right. There are many different Mukherjees. Now, are you based in India right now or not?
Yes, yes,
Okay.
I'm based in India.
So for
I'm in-
you may be more familiar with being on a panel with more than one Mukherjee, but based here in the US, it's very uncommon.
No, I totally understand. I think even in India, it's reasonably uncommon. I'm down in south of India, so I'm in
Okay.
Bangalore.
You're
So,
not in Bengal. Yeah.
Yeah, I'm not in Bengal. So in Bengal, you throw a stone and you'll hit a Mukherjee or a Banerjee or a Chatterjee or whatever. But
Yeah.
down here, it's pretty uncommon. So, but yeah, I mean, I was like, whoa, PHC to UHC, two Mukherjees.
Interesting.
Hi, Dr. Sivya, how are you?
Hi, how are you?
Burkina Faso, great. A bunch of people from Ethiopia, of course. You're hosting us.
So how would we manage the sort of questions? Would it all be chat with Amit sort of guiding us through the questions, or?
Yeah, so I can moderate with I know Baru, you'll work with me on that. Baru, feel free
Yes.
to let me know what I should be highlighting, but I can do the moderation and bring questions to you if that's all right. Of course, feel free to message me if you've got ones you particularly want to answer. So
Yes. You can also address some straightforward questions using the Q&A tab that you see next to the chat. So after you end like your presentation, if you got some questions that are straightforward to answer, like by typing right there, you can also do that. I think we can now start. Dr. Abnett, please.
Okay, thank you. Good morning, good afternoon, good evening, everyone. Welcome to another series of primary healthcare organized by the International Institute for Primary Healthcare. My name is Dr. Abnett. I'm the executive director there. Before we begin, I would like to give you a bit of information about the institute, and I would also like to take the pleasure to reintroduce to you our moderator for us here today. The International Institute for Primary Healthcare is an institute established by the Ministry of Health here in Ethiopia with the aim of becoming a global center of excellence for primary healthcare. We work in different areas and different platforms. We focus on capacity building for different sub-Saharan African countries, right now expanding to include other African countries. We provide support for the national Ministry of Health here in country as well. And amongst those, this is one of the webinars that we provide. With that being said, I would like to introduce you to our host, who is Dr. Svea Kloser from Johns Hopkins University. She's an anthropologist who's an associate professor in the Department of International Health. Her research focuses on the interaction between global health policy and local health systems, with a focus on building strong, community responsive primary healthcare systems. And currently she's working with IPHCE. She's leading the development of competency-based training curriculum for community health workers with WHO, and is also working with the government of Karnataka, India, to design structures to bring local government and health systems actors together to strengthen PHC. Dr. Svea is also an author of academic books published by Vanderbilt University Press and numerous academic articles in journals, including the American Journal of Public Health, Social Science and Medicine, and BMJ Global Health. And finally, she's a committed educator and co-author of 2 textbooks, Readers on Medical Anthropology and Global Health. With that being said, it's a great honor for me to introduce Dr. Svea. She will be moderating our session today, and I give the floor to you. Thank you.
Thanks, Dr. Abnett. It's always, I really enjoy these webinars, and welcome everyone. So good to have all of you here, and really looking forward to the conversation we'll have after these talks. So I'm really pleased to, what we're going to do today is have a few talks by 3 esteemed panelists. And each of them will take around 15 minutes. We'll have an introduction to the global landscape of UHC, and then we'll take a deep dive into, or a quick dive in 15 minutes, into the experiences in India and Ethiopia. And then after that, I look forward to having a conversation both between the panelists and with those of you in the audience. So please do, at any point, feel free to put your questions, comments, things you'd like to talk about in the chat, and we'll be pulling those into the conversation. I'm really looking forward to that. So our first speaker is Dr. Joya Mukherjee, who doesn't know this, but is a personal hero of mine. So I've been reading her work for years. So she is a doctor, educator, and activist, a physician. She's trained in infectious disease, internal medicine, pediatrics, and public health. And since 2000, she's been the chief medical officer of Partners in Health. Many of you are doubtless familiar with Partners in Health. It's a large international organization with programs across the world. So she's currently an associate professor at the Division of Global Health Equity at the Brigham and Women's Hospital and in the Department of Global Health and Social Medicine at Harvard. And she's also on the faculty of the University of Global Health Equity in Rwanda. So she teaches master's students and from around the world. And she's the author of Introduction to Global Health Delivery, which is a great book. And her recent scholarship focuses on UHC, which is why we have her here today. She's also, her bio tells me, a mother and a singer. I did not know the singer part. So thank you so much for being with us. And really looking forward to hearing from you about your work and your perspective on these issues. Thank you.
Great. And I see my fellow Mukherjee here is not at all surprised I'm a singer because we're Bengalis and that's what we do. So I thank you so much. I'm very honored to be here. I've, of course, heard so much about the medical system in Ethiopia over many years. Much of my work is in Rwanda, and I think Rwanda and Ethiopia together have shown a very clear path forward. And so I want to just review the lessons that we have taken at Partners in Health with our colleagues in the public sector across Africa and also in Haiti, about how to use vertical funding and HIV movement for the building of primary health care. So I just want to start with this slide because we always have to thank the activists across the world, from Thailand to South Africa, from New York to Uganda, who really changed our opportunities, especially on the African continent, who really said there is no way that we can have this amazing treatment, highly active antiretroviral therapy, for just less than 5% of the epidemic. We need to keep that movement and keep that fire as we face COVID and Mpox and all of the many pandemics that are coming, and the technology really trickles down. So really crediting activism and grassroots movements for the amazing success we've had across the world. They are the ones who put their bodies on the line to create lots of new money, from PEPFAR, the Global Fund, the creation of Gavi. So many of those things really came out of that movement, because prior to that, many of my colleagues will know this, who are my age and older, that there was very little healthcare delivery. We were almost exclusively focused on prevention, vaccination, vitamin A, deworming, and if somebody had a broken leg or pneumonia, there was no real treatment for people outside of mission hospitals. And so this movement for HIV treatment access gave us the opportunity to have money to treat HIV, but there were no systems of care in many places, particularly in rural Africa and places like rural Ethiopia, rural Rwanda, Malawi, etc. And so that became the challenge. In the US, sometimes we say it's when the dog catches the car. We fought for this money, we got the money, and now what do you do with it? And so I'm going to talk about that strategy and how that really, I think, informed a lot of work by many, many people. Partners in Health was one of many. So we made the decision that our HIV case finding strategy would be the provision of primary health care. And why did we do this? Because we saw that a lot of people were doing this kind of community-based education and trying to get people to get HIV tests, but people don't really come to care unless they're sick. And so to provide primary health care for people was a way to open the front door. And we did that through really doing 4 things with our HIV money. The first was putting staff in public facilities, because many of you know around the world, the public sector staff is underpaid, they're not supported. And so the primary care facilities are pretty much empty. So we used HIV money to say, this is not only for HIV, we're going to put staff to staff these public sector facilities. The second thing we did is put in basic drugs. Basic drugs, not only for HIV, but for malaria, for pneumonia, all of the things that people would be coming for. We reduced or exempted user fees, because those are, we know, a huge barrier to getting care for poor people. And then the 4th thing we did is hire and train and pay an army of community health workers who could go and tell people, healthcare is available at long last, right? And in this way, we saw massive increase in utilization from, public sector facilities that were just moribund to seeing 400 people a day, 300 people a day, because when you provide staffing and medicines, essential medicines, people will come. And then we could test for HIV. So, within months, we could see that these clinics went from very morbid, with no additional infrastructure, with no, just really the staffing and the stuff. Now, you have to keep up with that. You have to then improve the infrastructure and do all that. But that was how we started to find HIV. And in many of these clinics, this is in Haiti, within about 4 years, we achieved what we consider to be universal coverage of HIV. We found everyone with HIV. We put them all on therapy, but we also found tuberculosis. We also found people with schizophrenia. We found, women who needed additional support for pregnancy, who needed to be transferred to higher level facilities. So primary care was the engine for HIV case finding, but it was really the front door of getting people healthcare. And this was so important. So these are, our data from Haiti. the unintended consequence of this HIV case finding strategy, of course, was achieving universal coverage for infant vaccination, because again, once the doors are open, people will come. And so we had, many examples of the fact that there were positive synergies, and there was a report that we were part of at WHO that showed this kind of strategy of positive synergies using these vertical fundings to improve and base it in primary healthcare. Unfortunately, this is not always easy, and this is a slide that I've developed over many years with so many colleagues at ministries of health. What they see is the trickling in of money to their national plan, and the impoverishment really of the health sector. And meanwhile, there are lots of vertical monies coming through NGOs that really don't benefit the national plan, and instead are spent on things like behavior change education, which, while important, is not going to take care of a broken leg. The payment of consultants, people like me flying in, and train the trainer, which I think any of us who've worked in this space can say that those, kinds of meetings at five-star hotels, drinking tea, watching PowerPoint, are really not improving care for any vulnerable person. And so this is like draining the system. And so a lot of the work we've said is, if we map the disease burden and try to develop the supply side intervention, the staff, the medications, later the space and the systems, that is the way to improve primary healthcare. And to do that through the public sector, as Ethiopia has done, as Rwanda has done, is the way to get this truly universalized. So the countries that have been successful in this kind of strategy have done this, which is really force the money coming into countries to support the national plan. Rwanda has done this, Ethiopia, some other countries as well, Zambia, and to say, okay, these are our strong national plans, the money has to go there. And rather than having these constant, per diem economy, train the trainer, let's put the money for training into universities so that we can develop more primary care nurses and doctors and clinical officers, and that will feed directly into the health system. So, when you look at the countries that have done well, on the African continent anyway, it's because they've been able to strongly sort of push that money into the development, particularly of primary care in the public sector. So how do you do this? We've developed over many years a tool that kind of estimates, if you work in the public sector, you have a public health map. So you have a health center that has a population of 50,000. And in that 50,000, based on your DHS data, you can say, okay, we expect there will be this many HIV patients, this many people with TB, this many people with mental illness. And then you prepare the health center for that. So we have used some predictive modeling to say about how many people will we see based on the demographics of that catchment area, based on the surveillance, HIV surveillance, et cetera, based on the crude birth rate, and then try to develop the platform at primary care level to meet that need. And so we did that across 70 health facilities in Lesotho, which is about half of it's a tiny country. My Indian colleagues will be very jealous, only 2 million people. So with 70 clinics, you can cover half the country. And what we saw was doing this supply side intervention, and then really working with community health workers to generate, to have people accompany them to clinic, let them know that care is there, that lots of things improved. And so we mapped the medicines, and we were able to then prevent stockouts with the idea of progressively understanding what we needed. That was improvement of medicines and supplies. And we updated the human resources to meet the demand, because many people, if they come to a clinic and no staff's there, they're not going to come back. So this was all working with the government of Lesotho, you know, between Partners in Health and Lesotho. And what we saw, and we have many such slides, these are districts across the country, we saw that a massive uptake in utilization, and this is just infant vaccination. We have this for facility-based delivery, HIV, case finding and treatment. And so much of the improvement showed that the health centers and provision of primary care became the centers for activity. The brown is number on the left is the number of children getting vaccinated at hospitals, which, you know, again, we know is not a tenable strategy, right? And then this increased utilization in clinics, which is what you want to see. So to end my brief presentation, we believe that, you know, coverage, which a lot of people talk about in UHC, about insurance, coverage is important, of course, but if we have an insurance card, and I'll quote one of our ministers of health, Dr. Jola in Liberia, I could give everyone a card tomorrow, but the card would not afford them anything because our health system doesn't work. So coverage with insurance without improving the delivery will not achieve UHC. And we believe that there are ways you can map the need to the actual supply side delivery in terms of staff and stuff that will allow people to always find a provider and medicines, and then really start to get to the burden of disease. So very short, but that's our experience across Haiti, Rwanda, Liberia, very different places, Malawi, Lesotho. And we've seen that definitely on universal health coverage, many of these countries are achieving universal health coverage for HIV. We're getting there for a lot of other conditions. And so I'll stop there. Thank you.
Thank you so much, our first Dr. Mukherjee. And really appreciate that, and some really interesting and provocative thoughts and comments. Really appreciate that. So we'll have a conversation with all the panelists after the three talks. I see there are hands raised, which is great. You can also put your questions in the chat and we'll get to them, but we'll have a discussion after our other two panelists. So our next panelist, I'm very pleased to introduce a friend and colleague of mine, Dr. Temesgen Ayehu. He's Primary Healthcare Director at AMREF Health Africa in Ethiopia. He has an MPH in Health Systems and Policymaking. Before joining AMREF, he served as the Director of Primary Healthcare for the Ethiopian Ministry of Health, leading the development and implementation of many different initiatives for primary healthcare across the country. He has 15 years of experience working with the Ethiopian Ministry and other NGOs on primary healthcare. So thank you so much, Dr. Temesgen, for taking the time today. Really looking forward to hearing your thoughts on UHC.
Thank you so much, Dr. Sylvia, for the introduction, and I'm very pleased to share Ethiopia's experience on using or strengthening primary health care to improve the path towards universal health coverage. So I'll try to focus on the key initiatives that Ethiopia implemented to strengthen primary health care on the path towards universal health coverage. So this will be the outline of my presentation. I'll give you a brief country background about Ethiopia and the health system context and how PHC support the achievement of universal health coverage and the UHC performance in Ethiopia, the key PHC initiatives to achieve UHC, and summary and the current challenges that the Ethiopian primary health care is facing. So maybe in the interest of time, I'll try to be fast in the presentation. So Ethiopia is located, I think many of you know, in the eastern part of Africa with an area of 1.1 million square kilometers. And the population is estimated to be around 109 million, which makes it the second most populous nation in Africa. And majority of the population lives in rural areas. And as many African countries, Ethiopia is also in the demographic dividend, where more than 65% of the population is aged less than 25 years. And the country is known for diverse with its diversity, with around 80 plus ethnic groups, and administratively, Ethiopia is divided into 12 regional states and 2 city administrations, and major economic growth contributions for Ethiopia are agriculture, industry, and the service sectors. When we see the health system, so currently the Ethiopian health tier system is divided into 3-tier health system. So the first one is the primary care level, and there are areas we have health posts, health centers, and primary hospitals, which constitute the primary care level. And in urban areas, it's the health centers that are considered as a primary care level. And the secondary level is general hospitals, followed by specialist hospital. When we see also the policy context, including the health policy, and also the strategic documents, mainly focus on primary health care and universal health coverage. Like, for example, recently, the revised health policy is endorsed by the Cabinet of Ministers. And when we see the policy directions, it focuses on primary health care towards achieving universal health coverage, like enhancing the quality and equity of health service, the community engagement and ownership, improving the health system capacity, financing, and the multi-sectoral collaboration or health and health policy. So all these strategic directions are very much in line with primary health care components and also the UHC aspects. So maybe for today's discussion, using primary health care in the eye of UHC. So this table from WHO is one of the interesting tables that I found. How we can see or the alignment of primary health care and also UHC. So as we all know, primary health care, it has mainly 3 components. One is integrated care, which includes primary care and essential public health functions. The second component is multi-sectoral policy and action. And the third one is empowered people and communities. And the UHC, the 3 triangular dimensions that we all know includes the financial protection, the quality of services, or expanding the services in that dimension, and also the equitable access, which means covering populations. So from this table, we can see how each component of PHC helps us to address UHC. Like, for example, if we see the multi-sectoral policy and action, how it can help addressing the financial protection. So through multi-sectoral policy and action, we can address underlying determinants that will prevent ill health and also promote well-being. So this will reduce individual care and finally reducing expenditure for healthcare. Similarly, multi-sectoral policy and action also can reduce the burden of disease. Like, for example, through education, improve nutrition and livelihood, we can reduce the burden of disease that will also prevent the treatment or ill health conditions, and also save resources that will help to improve the quality and safety of healthcare. So primary healthcare and UHC are very much linked. With this context, when we see the universal health coverage performance in Ethiopia from 2000 to 2021, there is a progress, especially from 2005 to 2017. There was a huge progress in terms of UHC service coverage index. When we say this service coverage index, it actually includes around 14 tracer indicators from RMNCH, infectious diseases and NCDs, and service capacity and access to categories. So the progress specifically from 2005 and 2015 was significant. So in my next presentations, I will try to highlight what we have towards UHC, even though the achievement is not satisfactory by now. So the first one is investment on health inputs or health system inputs. One is infrastructure, and the other one is on health system or on human resource for health. So when we see the investment on health infrastructure, as we can see from the second graph, if you see specifically from 2003 to 2010, there was a huge investment on expanding the number of health posts. And so as we can see from the graph, from the number of health posts from 2000 to 2010, it's expanded from around 0 to 17,000 health posts. Similarly, the health centers were also expanded hugely from 2018 to 2012. So this is actually due to the policy from the Ministry of Health towards accelerated expansion of primary healthcare in the country. So after the expansion of primary healthcare facilities, which means hospitals and health centers and health posts, it was also followed by a similar expansion of hospitals. So in terms of time, when we see starting from 2013 and 14, there is also a huge expansion of health posts. So this helped to expand the primary healthcare in the country. So similarly, when we see the investment on human resource, so as we can see, primarily it was started in increasing the number of nurses, followed by midwives, health officers, and general practitioners or specialists. So majority of these health professionals were deployed in primary healthcare facilities, providing essential health service packages. So this investment was huge in terms of strengthening and capacitating primary healthcare. And the other component of, when we see this UHC dimensions, so one dimension is the service coverage, or which services are being covered through essential health service package, and the other one is the payment mechanism. So Ethiopia first defined the essential health service package in 2005, and later this essential health service package was revised using 6 prioritization criteria. So currently, a total of 1,018 interventions were selected as essential health service packages, so that to expand UHC. And what we can see the importance of UHC is about 60% of the interventions will be delivered through the primary healthcare level, which means community health post, health center, and primary hospitals. And this essential health service package has also defined the financial arrangements for the services. So majority of the services, for example, like immunization, tuberculosis, family planning, and delivery, will be provided freely or exempted service through government and also donors' contribution at the primary healthcare level. And the second financial arrangement is the cost sharing, where 38% of the service will be provided. These include emergency and critical care, and the remaining 6% is going to be provided through a cost recovery mechanism. And the other important primary health care initiative that helped to expand UHC in Ethiopia is the health extension program, which helps to empower individuals and communities. And as we can also see from the name, it helps to extend essential health services, especially to the rural and vulnerable communities. So the program was introduced in 2003, and it delivers high-impact health promotion, its prevention selective curative services, packaged in 18 health extension program packages under 4 components, which includes family health, hygiene and sanitation, disease prevention and control, education, and communication aspects. So mainly to health extension workers are assigned in one health post to serve a population of 3,000 to 5,000 population. Currently, there are 42,000 government salaried health extension workers that deliver services through home-based, community outreach, health post-based, and also activities conducted in youth centers and schools. In addition to that, health extension workers are also supported through an army of women to engage the communities, and another mechanism to empower communities is also representation of community members in health facility governance boards. So the evidence has also shown that the health, especially from 2003 to 2018, the health extension program contributed for significant improvements in maternal and child health, communicable disease, hygiene and sanitation, knowledge and healthcare seeking behavior of the community. And also other evidence shows that the health extension program has a return on investment of $1 invested in health extension workers. There was a net benefit of approximately 3.71. When we see this one with other studies, like for example, other studies shows that the health extension program has return, like a community health program has a return investment on $1 for $10. But in the Ethiopian context, the investment includes the construction of health posts and other aspects, not only the community health workers. And similarly, the women development strategy, so higher implementation and strengths was associated with better healthcare behaviors and practices. And similarly, on empowering individuals and communities, probably the fourth critical initiative was also a community scorecard, which is a community-led governance tool that brings primary healthcare facilities, local government structures in the community to promote social accountability and responsiveness of the health service, specifically the primary healthcare service to the community needs. It was actually introduced in 2017 and currently scaled up in all regions. Now 80% of health centers are implementing this community scorecard. Similarly, the evidence also shows that this community scorecard implementation improved KM in its maternal neonatal and child health indicators. The fifth one and also the sixth one, I try to focus on innovative primary healthcare service delivery approaches, mainly covering like the population or who is covered and targeting vulnerable communities. So one of the approaches that was introduced in urban areas as part of the urban primary healthcare reform is the family health team. So this is a service delivery mechanism, so a multidisciplinary health teams that includes medical doctors, nurses, and also community health workers. So it includes targeting of also vulnerable households. So the main feature of this reform or family health team, one is establishing the family health team, and the second one is the empanelment and categorization of households based on their health and economic status. So based on that, the households get priority and also delivery of service. Currently, this approach is being implemented in 170 towns in 359 health centers. So as part of improving health equity in urban areas, this is one of the strategies. So for example, as we can see from this table, this is how the categorization of the household is being done. So after collecting household data, so as we can see from the column, one of the columns, we can see households are categorized based on their health status. So whether there is a pregnant woman and under 5 children, whether that household is with emergency and chronic condition, and also the third will be other conditions or no health condition. And the other category is economic status. So based on the household properties, they will be categorized as low income, medium income, and high income. So as we can see from this one, like for example, a pregnant woman from the low economic status will get the priority, or a household with under 5 children and a low economic status will be the priority number 1. And the second priority will be households with emergency and other chronic conditions, and also with a low income status. And the other categories also will get the service as based on their category. So this helps to target health services and also identify and provide essential service for vulnerable households. Similar in pastoral context, the service delivery through the multidisciplinary mobile health service delivery model is also another approach to expand the UHC, especially on the population coverage. So there are 2 types of modalities that are being currently implemented. One is a full-time mobile health team. So with this approach, a mobile health team, similarly a multidisciplinary team, will move with the pastoral community and provide essential health services. The other one is a facility or district-based mobile health team. So when there is a need to provide health service, or if there is a barrier to provide health services for the communities, the mobile health team will be established and provide service. So this is, for example, the example that's being implemented by Amref Health Africa in 5 districts. So like, for example, so 8 rounds of mobile health service, we managed to provide essential health service for around 48,828 people through the mobile health service delivery model. And the 7th and important aspect of UHC is also the financial risk protection. So the community-based health insurance is one of the interventions being implemented in Ethiopia to prevent financial catastrophe. So the piloting of this initiative was started in 2012 and up to 2014. And starting from 2015, the implementation of the approach is being scaled up, and currently around 1,052 or 81% of the districts are implementing this community-based health insurance, and currently around 11 million households or 78% from the total eligible households in Ethiopia are enrolled, of which 2.5 million are indigents or who are unable to pay, and that's covered by the government as well. So the other important thing that we can see here is from the services or the payments made through community-based health insurance, 53% of the service utilization is happening at health center level. So we can see how CBHI is protecting financial protection, but also how the primary health care, specifically health centers, are playing essentially role in service provision. I would like to mention the Warada District Transformation Initiative, which really helps us to package the UHC context for a local context. So you see, in Ethiopian context, the district is a critical administrative structure in terms of health service. So since we are following a decentralized health system, the district health system is the critical administrative unit that provides technical and administrative guidance for the primary health care facilities. So in our context, this district transformation almost a UHC at the Warada or district level. So if we see the indicators, like one is community-based health insurance, which is linked with the financial risk protection component of UHC. The other one is the high-performing primary health care unit. So for this, we have key performance indicators, which is also linked, or the indicators, the 17 and so indicators are linked with the coverage of essential health service components of the UHC. And the other one, the model coverage, includes the model families, the community engagement in empowering households component of UHC, and also the service coverage of the UHC context. And Warada management standard is one of the indicators as well. And districts are being assessed using this indicator, and the last indicator where 706 districts are assessed. I think like 15% of the districts were categorized as model, 20% medium, and the rest low and very low indicators. But last year, Amref Health Africa, in collaboration with the Bill and Melinda Gates Foundation and also the Ministry of Health, conducted an assessment of the primary health care using the WHO primary health care monitoring and indicator frameworks. And we assessed the capacity and performance of primary health care in Ethiopia. So despite progress, still the primary health care in Ethiopia has challenges. Like, for example, when we see the inputs in terms of physical infrastructure, availability of essential input, amenities, and also medicines and supplies. And there is also limitations on quality of care and also coverage of some services, despite the progress that we have seen earlier. So in summary, Ethiopia registered significant progress in health access, service utilization, and health outcomes over the past 2 decades, and primary health care was the key component to achieve this achievement. And the success factors for the road towards which include: 1, policy and program levers. So majority of the health policy and strategies were policy focused, and the other one is investment in health system imports, including infrastructure, human resource, and also the gains or improvements made in individual and household level improvements, including economic change, education, improvement in living conditions, and WASH. But still, there are remaining challenges that we need to tackle if we want to improve the path towards universal coverage. One is improving the multi-sectoral engagement. So currently, except in some areas like nutrition, WASH, HIV, and training of health workers, there is limited multi-sectoral engagement. The other one is high disparity in access and utilization, especially among regions. So if we see some of the indicators between agrarian and pastoral regions or urban and rural, there is a huge disparity. So we need to narrow that one. And the lack of availability of basic amenities, improving the motivation of health workers, including health extension workers, and addressing conflicts and emergencies are some of the challenges that we need to address to maintain the momentum and improve our path towards universal health coverage. Thank you very much.
Thank you so much, Dr. Temesgen, for that really interesting presentation. A lot of parallels already between these two presentations. Again, showing the importance, as Dr. Joya Mukherjee brought up, of staff, stuff, and systems coming through in the Ethiopian example as well. So our third panelist today is Dr. Arnab Mukherjee. I'm pleased to welcome him. He's a professor at the Center for Public Policy at the Indian Institute of Management in Bangalore. And he's an economist, an applied microeconomist, and his work focuses on the economics of healthcare and governance. So he's working on international and interdisciplinary research teams with Duke and McGill universities, and works closely with the governance of Karnataka and Bihar in India, two large Indian states, as well as the World Bank and the Asian Development Bank. He's author of a book titled The Story of the New Bihar, which was released by the President of India. And his research has been published in many prominent journals, including the American Journal of Public Health, BMJ, Economic Development and Cultural Change, as well as many others. We're so pleased to hear from you today, Dr. Arnab Mukherjee, and really looking forward to hearing your thoughts on the Indian experience with UHC.
I almost forgot to unmute myself, so it's a pleasure to be here. This is a really exciting forum for me. I've sort of, never spoken to an audience of this nature. I'm a little hesitant also, as I'm sort of an economist speaking to, I think, a tribe which is much more clinically and medically aware of things than an economist usually is. So with that as a backdrop, what I'd like to do for my 10 minutes is to essentially set out a little bit of an agenda in terms of like what the government of India is trying to do through its attempts to achieve UHC through the primary healthcare channel, and subsequently talk a little bit about some of the work that we are doing as a part of the Lancet Citizens Commission on Reimagining Healthcare in India, which looks at one part of this puzzle, where I would be talking a little bit about our experience with understanding how there's variation in UHC within any country, and how that variation leads to thinking about different strategies and pathways for achieving UHC. And it's going to be a very complimentary presentation to both the prior speakers. So with that, let me just sort of get going. If one looks at India, India sort of had a so GOI is Government of India. Government of India has had a very strong commitment, both on global sort of forums as well as locally towards the idea of universal healthcare. This is partly formulated as a part of its National Health Policy of 2017, which doesn't use exactly the same definition that's used globally, but it reads very, very similarly to SDG 3 and the definition of UHC, where the idea is to have a health system that looks at achieving the highest possible level of good health and well-being, and thinks of health as a public good. The universal aspect of this is being sort of pushed for, I would say, about 20 years now as a part of the National Rural Health Mission, which has now become the National Health Mission, which looks towards essentially universalizing services from mothers and children. And now it's sort of looking more significantly towards NCDs. In fact, until COVID, NCDs had become the major focus. With COVID, there's now been a refocus, not just on infectious diseases, but also in the country on primary health, because the primary health became the first portal of call for essentially dealing with COVID. Some of the major challenges, the first one, of course, is we are a lower middle income country, which still has a very high burden of diseases like malnutrition, some types of infectious diseases that vary geographically from state to state within the country. But also we have a very high load of non-communicable diseases. In fact, you may be surprised to note that 62% of all deaths amongst men is from NCDs, and 52% of women is also NCDs. So that's in terms of this like dual burden of disease that the country faces. At the same time, it's very similar to some of the points being made by Dr. Joa and Temseya. There is a fragmentation of healthcare systems in India. So we've always been a country where healthcare systems are a referral service. So that means that you have close to your village a sub-center, which is essentially a birth clinic with very minimal additional services. If you need additional services, you're referred to what's called a primary health center, which is anywhere between, being in your village to about 5 kilometers away. And that's essentially someone who's a medical doctor who could sort of provide first aid, do elementary diagnosis, but does not have significant specialization. To get specialized care, you'd need to travel to a district hospital, which could be anywhere between 30 to 50 kilometers away. And so therefore, there is a challenge in terms of accessing systematic healthcare. Often the sub-centers, which is what's accessible, is out of stock of all kinds of medicines. And some of the points that were being made by Dr. Joa about how HIV was an interesting trigger is also sort of something which would be very relevant in the Indian context, because there needs to be a local trigger to sort of start activating the availability of services, which goes across this. But while this public channel exists, in parallel, we also have a private channel. Some of it is essentially through private medical providers who have gone to medical college and are practicing. And there's a third group of providers who do not have any medical training, but are also dispensing medicine. So these range from somewhat safer places like pharmacies, all the way down to people that one would, call, jhola chap doctors, or, people who just carry a bag and are distributing medicines. So there is regulated and unregulated care also being provided. So the fragmentation of the health system is quite significant, quite large. And for a lot of people, the first port of call is actually your informal provider rather than the formal system, essentially because it's hard to get to the formal system. The informal provider will come to your home and you can get access to care. So that's on the supply of care. On the demand side, we are a country which continues to be a very high out-of-pocket system. Close to 60 to 65% of all medical expenses in the country continues to be out-of-pocket. This is not through insurance. This is not through tax-funded expenditures. And so unless you have funds, you do end up missing care. And when you desperately need care, getting care also drives you into poverty and indebtedness in a fairly significant manner. So, in this kind of a context, if you look at approaches towards UHC, the government's essentially done a set of three things. The first one is a commitment to spend more money. The government currently spends about 1 to 1.5% of GDP on healthcare. In addition to this, there's another 4% or 5% of GDP, which is the out-of-pocket payment that the country is making in buying healthcare. And so the government has committed that in the near future, we would hit about 2.5% of GDP, which is almost doubling the extent of money that's available on the table for healthcare. The plan for sort of this is to essentially look at two broad strategies. One is a social health insurance strategy, which is called Ayushman Bharat, which essentially looks at tertiary and secondary care integrated across the entire country. It's a forum in which public hospitals, but mostly private hospitals, become available for people below a certain income threshold to access healthcare. And the second sort of part of this is essentially the primary healthcare channel, which is what's called the health and wellness centers. The health and wellness centers are essentially an amalgamation of the sub-centers that I spoke about earlier and the primary health centers. And the belief and challenge is that we would take these existing structures, which are fairly weak, don't have a lot of medical supplies, and put in some additional resources, both physical as well as human, in terms of doctors, nurses, medicines, and upgrade these facilities to essentially provide what's called in India comprehensive primary care. And this is to be available to everybody across the country, is meant to provide free essential medicines, give you access to diagnostic services, and have very, very low user charges. So this is sort of essentially something that has been in place since about 2017, 2018. The verdict on how effective this has been is not yet out. There are some initial studies which show that some model HWCs are really amazing, but there's also evidence to show that this has not yet been a wide sort of net that's been cast. Aside of this, of course, is the social insurance scheme, which I will not speak too much about because this is essentially secondary and tertiary and is meant for sort of accessing, fairly significant curative care that has expenses. Now, if one sort of goes into thinking about, UHC, what one typically has is a number for the entire country. So as a part of the Lancet Citizens Commission, one of the first things that we did was we said that, well, let's try to break down this number for the country into a number which makes sense from a planning, targeting, and access perspective. And so what we did is we took the WHO World Bank definition of universal health coverage, which includes these definitions, which includes these set of 5 domains. And for each of these 5 domains is a range of measures. And what we did is we essentially said, well, okay, let's look at reproductive, maternal, newborn, and child health, see how it's measured, look at national population surveys where they exist, look at administrative data where they exist, and use all of this in the same place and try to create like this assessment of not what's happening at the national level, but what's happening at the local district level. So the country in India has administratively the national level, the state level, and below the state is the district level. So the district, all districts have a hospital, all districts break down into what are known as blocks. And in the blocks, you typically have 3 or 5 primary health centers. And for each health center, there's anywhere between 2 to 7 sub-centers that are mapped on. So essentially, it's trying to understand the district as a health system and not necessarily the country as a health system, because we anticipated that there'd be wide differences in terms of the level of access of universal healthcare. And it's not just about geographic differences, but also about domain-specific differences, which would be across each of these 5 domains. So you have apart from the first one, you have infectious diseases, non-communicable diseases, service capacity and access, and financial risk protection. Now, if we sort of follow the methodology that was sort of proposed and implement that, this is what India kind of looks like. The blue parts of the country have better universal health coverage. The red parts of the country have worse health systems. Effectively, what you see is that the southern part of the country has better health systems. The northern, particularly the middle part of India, is bright red. This is Bihar, this is Uttar Pradesh, parts of Jharkhand, parts of Orissa. So these are districts which are also not just having poor health outcomes, but they also have poor economic outcomes. So there's a very strong correlational story. Most people I've shown this map to, they kind of nod their head saying, well, yeah, this is what we would anticipate based on our prior assessment. So what we did is we kind of looked at a series of districts which are at high, medium, and low levels of UHC coverage in the country. And we visited these districts and we started asking them questions around, well, what does it mean for you in terms of universal health coverage? And how do you think we'll get there? And what are some of the key barriers that seem to prevent you from getting there? And what are the key things that have been happening in your district that you think will push you towards UHC. And so what I'm going to do is, for the rest of the few minutes I have, I'll speak about West Singhbhum, which is up in the north, in the middle of the country, and Kerala, which is down in the south, west of the country. So if we look at Kerala, which is a high-performing state, and within Kerala, if we look at the district of Thiruvananthapuram, which is like at the fag end at the bottom, a southernmost district, we find that this is a district which is very high UHC coverage, even within Kerala. Now, this is a state which has 334,000 people. It's got very, very low mortality rates, reasonably low infant mortality rates. It's quite strong in terms of its access to health insurance, and generally a lot of NCDs seem to be well managed. So if you sort of look at the state also tends to have a number of vector-borne diseases, so Zika virus. In fact, this it is also very strong on surveillance. So they were actually reporting far higher numbers of COVID when COVID struck the country, essentially because they have a very strong surveillance system, whereas most other states were not able to detect this. Now, if you look at our surveys are of users of the health system, para-health workers of the system, doctors of the system, pharmacists of the system, public doctors, public administrators of the health system. And so it's this group of 6 people that we spoke to. And I think what comes up from Kerala is that they have a very strong health and political movement historically, which has led to not only very high levels of education, but that level of education also was paralleled by a sense of decentralization of political power at the district level. And this allowed for local systems of governance to come in and demand for primary healthcare as a way of asserting their identity and their sort of need for services. And in this process, local communities have innovated in a number of very, very interesting ways. And that sort of helped the state do really, really well in terms of understanding of how to, push health systems out. They have looked at panchayats, which are village governance systems, to essentially look at primary healthcare centers. There's a number of small innovative examples of institutional innovation, such as the Ardham mission that sort of, looks at taking the primary health center and enabling extension of its services to local communities. It does really well on palliative care. This is one state which has the highest life expectancy in the country, and therefore this is a very important concern for the state. On the other side, if you look at barriers, most people said that, look, access to healthcare is still quite problematic in Kerala, even though it's a very high UHC district because of high out-of-pocket expenditures. Often you have to travel long distances, and sometimes the resource staffing constraints are really messed up. And so therefore you don't have the right mix of doctors, nurses, or even the right mix of specialists that you need. And often when you do get good services, you find that people have changed and there's high turnover. And so there is no community sort of relationship with the healthcare provider that sort of emerges. And those are obviously things that are not very good in the long term in the primary healthcare space. The second district that I'm going to talk about is this district of West Singhbhum. This is a mining area. This is very backward. This has very low indicators. The government of India has a list of 200 districts that are the poorest of the poor, and this is one of those 200 districts. And again, it's about roughly the same size in population, but as you will see, maternal mortality rates are much higher. Infant mortality rates are a couple of times higher. So death, disease is much more in this state. There's a significant burden of undernutrition amongst children, mothers, adolescents, and a range of communicable diseases. Also, there are some mining-related sort of challenges from the health front that this district sees. And so what we found is that a lot of faith healing sort of happens in this district, and in this space, the community workers, they are called ASHA workers, the accredited health activist, and people's movements that exist have essentially enabled people to feel like they have access to healthcare. And when they don't find the doctors, the community mobilizes to essentially push the health system towards providing care to a person who needs it. And so in doing this, the government has sort of tried to come up with this AAA strategy that they have. So this includes 3 types of para workers: the ASHA, who's a health ministry worker, the A&M, who's a nutrition worker, and the Anganwadi worker, who's a early childcare maternity worker. So the 3 workers work together at the village level and are able to negotiate complexities and lack of care at the village level, at the block level, and the district level to ensure there's coordination of care. And so the patient and the patient's family is not left looking at it. And finally, the national policy on the National Health Mission has also sort of helped the state in many ways in ensuring that there are sustained inputs in terms of building of facilities, building of pharmacies, strengthening of logistic networks, which a lot of people talked about in the state. But there are a lot of barriers as well, and a couple of barriers are essentially related to the fact that the population in Jharkhand has a number of tribal sort of communities, so the languages in the district itself is not common. So often doctors, nurses, and patients don't speak a common language. There's significant poverty. So often in a high out-of-pocket system, often having funds allows access to care. That's not going to work in this kind of a space. This is a state which does not have public transportation for some reason. I don't know what that is. But because it doesn't have access to public transportation by design, it's problematic to access healthcare if it's not at your doorstep. There's low literacy, there's frequent transfer of health professionals. And in addition to the usual problems with governance system, there's also a parallel governance system, which is a tribal governance system, which also determines what is appropriate, both in terms of location and placement of health services, as well as the kind of health services to demand for and that generates complications in terms of the health ministry's ability to reach out and provide care in a systematic and sustained basis. So that's it. So that's the end of my talk. I mean, I think the key takeaways that I'd like to leave behind is that generally there's a big focus on sort of looking at both primary healthcare as well as UHC, and that this is actually fairly complex with a lot of variation within any given country. And if you can identify what those variations are, you'll find that there are very different kinds of things that you might need to do at different locations. However, many of them line up into some broadly similar sounding buckets. Yeah, over to you, Dr. Sveya.
Thank you so much for that really interesting presentation. A lot of parallels with the previous presentation, and also thanks for your emphasis on the need for context specificity, which is an endlessly challenging project in countries like India and Ethiopia. Yeah, so thanks so much. I'm really looking forward to about 20 minutes or half an hour of discussion amongst all of us. So please do feel free to put your question in the chat. I also see there's a raised hand, which I'll get to in a moment. But I want to start with a really interesting question that a couple of our participants have raised in the chat, and that is around the question of the private sector. Several participants have asked, how can UHC work across the public and private sectors? How can it be structured? Yeah, are there any models that any of you have seen of engaging the private sector in UHC? That's a fantastic question. I don't know any off the top of my head, so I'm really interested to hear if any of our panelists know of any models of engaging the private sector effectively in efforts to provide UHC.
Yeah, I can take a shot at that. So yeah, like I think that in some of the countries in Africa, Lesotho, Malawi, the missionary hospitals, which are private, so the CHAM, sort of Christian Health Association Malawi, Christian Health Association of Lesotho, are considered part of the public sector map. Now, I think there's problems in terms of harmonization of services. Often those are facilities that charge user fees, whereas many of the public sector facilities don't, but they are part of the public sector map, and they are considered part of the catchment area, and with some support can be part of it. On the other side, I do think we've had our experience at Partners in Health is often the private sector is extremely hard to manage, particularly with diseases of the poor, tuberculosis, HIV. I know there's some examples in India of private providers providing tuberculosis treatment, but I think very hard to do the overall mapping that it would take to really achieve coverage, universal coverage. But I think there are some examples, but one has to dig.
Yeah, Dr. Temskin. Oh, sorry, go ahead.
Yeah, no, I was just going to say I'll go after Temskin.
Thank you, Dr. Sylvia. I think in addition to what is already said, I think there are also experience of engaging private sector in service provision, like for example, through social franchising. We can also see the experience from many stops clinics where they have what they call a Blue Star clinics, and through social franchising where they provide services, services. So this is one sort of engagement of the private sector, but we have also other models, including the government and private working together. Like for example, in malaria, TB, and HIV. This is also the experience that we have in Ethiopia, where the government provides medicine diagnostics and also training and other supports, and the private sector provides the service similar to the public sector. So this is one area of extending the services using the private sector as well. But as one of the questions mentioned earlier, the private sectors can have a role besides service provision. Like, for example, the professional associations can take the role of licensing the health professionals, but also the health provider as well. So in general, I think the private sectors, engaging the private sectors can improve access, quality, but it also helps to regulate the private sector as well. So we can see in a broader scale as well. Thank you.
So, I mean, in the Indian context, I think what we find is that there are certain types of things that are much easier to privatize. So, for example, diagnostic services, ambulance services, these have been privatized quite nicely. However, there are other things that are very, very hard to privatize. For example, screening, for example, trying to ensure that, vaccination sort of takes off in a nice way. And so it's a really hard sort of question, especially because, the private sector is a very focused entity looking for profits, and therefore the entire organizational structure is, designed to contain activities that lead to profit creation. And in the public health space, that's not the case. I mean, there are externalities, there are like all kinds of things that you have to be worried about. And it's in this space, there are a number of examples of private players who have entered primary healthcare, who have also left the primary healthcare because they've realized that it's very expensive and it's very hard to essentially provide very detailed models. However, there are some non-profit organizations, and there are some for-profit, full-service primary healthcare models, but they have not been able to scale systematically to be relevant in the context of a national health system. So there do exist models, but they are contained, small, and I think we in the commission in India, we're sort of debating this. There's a group of our colleagues who are very keen on bringing in managed care into primary healthcare. But there is another group of us who are very skeptical of this, and we're worried that that just generates the wrong incentives, because then you start prioritizing certain kinds of things and not others, which is not the purpose of primary healthcare. So I think from that perspective, this is a hard first question to start off with.
Yeah, I mean so I've got a couple other hard ones to throw your way to follow up with that one. Our audience is quite sophisticated and not making it easy on you at all. So the next question I want to throw your way, following up on that tough one, sort of another dynamic at play here. Of course, you've got government PHC health systems, you've got the private sector, which we just described is quite challenging. And then you've also got, and Dr. Joya Mukherjee's presentation sort of alluded to this, you've got a lot of different vertical programs coming through from usually international actors, right, who have particular funding streams and particular agendas. And, thoughts on that, yet another complexity. If there's sort of best practices on how to deal with these vertical programs in a way that supports the goals of UHC. And Dr. Joya Mukherjee's presentation spoke to this a bit, but yeah.
What's the question, Svea?
The question is just, are there best practices, or how best to do this? How best to think about it? Are there great examples beyond the one of HIV, and Partners in Health, which is a great example? Are there other best practices or other examples of how this can be done?
Sorry, Dr. Silvia, is it about the diagonal investment that one of the participants mentioned?
Yeah.
Yeah, I think as earlier mentioned by Dr. Joya, the Ethiopian primary health care in general, and the health extension program is also one of the examples where diagonal investment has improved the health system. So through these specific investments, like for example, through the Global Fund for Malaria, TB, and HIV, and also from the support from Gavi on immunization, and the government channel that went through one plan, one budget, and one report or harmonization model to improve the health system. So maybe the investment, it comes for specific diseases, the funding, but the investment was overall to improve the health workforce in general, the health information system, the supply chain, the infrastructure, and all. So this is how diagonal investment can help to improve the health system in the primary health care through these specific investments. So there is also a published report on this. I can also share that one, the link in the chat as well. Thank you.
That would be great. And I think, one of the things that's interesting about both of these, they both require some pretty strong and creative work on the government end to try to manage all these different actors in ways that support the health system. Yeah.
And of course, I mean, I think there are a couple other examples. It took me a minute to come up with them, but I think if we look at Asia, particularly Thailand, the government use of sin taxes to fund a health system, and the specific focus on rural healthcare through the Prince Madahal kind of initiative to get providers in rural areas, I think have in fact transformed the health system in Thailand. Again, strong government mentality, but using private sector sort of taxes and revenues. I think that's one. And then you can look at other countries like Botswana that use nationalized revenues from diamonds, for example, to pay for healthcare. So I think less about the public-private partnership and governments trying to tap into private sector funds through taxes or other means to earmark that for healthcare. And we see that in the US to some extent with the tobacco money. So I think there are ways to not necessarily rely on the private sector per se, but to harness revenues from the private sector. I mean, Lesotho is an example whereby the PPP has been just an abject failure, a massive private public hospital run by the South African HMO Netcare that was built with public debt, World Bank debt that does not serve people, period. And so I think we've got like numbers of examples like that as well.
Yeah, thanks. I see Michael Domingo Banda has had a raised hand for most of the, he's been very patient. So please go ahead and ask your question. Oh, we can come back to him. All right, one more. We've got some other big, difficult questions for you here. How to engage other sectors. So we've got the beyond the private sector and international actors with vertical programs. Of course, there's other government sectors. So are there strategies for effectively engaging other sectors? I mean, Dr. Arnab Mukherjee talked a bit about Tamil Nadu, which has some interesting examples there. But I'm wondering if you can speak a bit more about that, or if others of you have strategies or ideas for that. Yeah.
So there's a lot of experience there. I mean, quite clearly, like the WASH group of government departments, so water, hygiene, sewage, these have a really big role to play. There's nutrition, there's education. So all of these sort of are very natural parallels. I mean, in some countries and in some states, they're part of the health ministry, in others, they're not. They sort of have parallel purposes. And the state that I talked about, Jharkhand, which is essentially got this AAA model, which is trying to look at health providers of these multiple departments to work together at like different scales of governance, is a very nice way of trying to get that intersectionality going, so that challenges that are locally emerging can essentially be highlighted to the health system and the right part of the health system, because then that sort of allows working to sort of take shape. But the Tamil Nadu sort of experience is one in which I think the revenue department is working with the health department to essentially ensure that there is safe, reliable procurement of medicines, so that essentially enables all government health facilities to have stable prices and systematic access to medicines. This is the best in the country. Many other states have tried to copy the Tamil Nadu model. They've picked up the design and tried to implement it in their respective states. In most states, it's failed spectacularly. It's a weird combination of people, of bureaucrats, and essentially the way they engage with each other that makes it work in Tamil Nadu and doesn't in other states. The other kind of thing that I think is really important, and we have seen evidence for this, is that in most states, people tend to access the health system through public transportation. And in the absence of public transportation, when you have like a tiered sort of health structure, you would have difficulties and challenges in having UHC. So transportation, I think, is another major part of like this other parallel complementary sector that would be playing a big role.
Great, thank you. Other thoughts, or I can move on to another question too.
Maybe I can add one point. I think, as already said, this multi-sectoral approach, it's one of the components of primary health care, mostly discussed, but one of the challenges to implement. We know, like, this is for the achievement of immediate the contribution of other sectors and non-state, non-health activities were critical, but bringing relevant sectors to improve health is also one of the challenges when it comes to the implementation level. So probably one of the approaches to use is probably the design and implementation of the health in all policies. So how can we develop health in all policy and influence health in all other sectors? So for example, when you develop a housing project, how can you make sure that from the beginning includes the public health and health aspect? And also when you develop a food policy, how can you integrate, for example, the iodization and including iron fortification, some of the aspects like that. So having the health in all policy at the national level and enforcing that policy will help to address multi-sectoral approach. But even at the sub-national level, whether it's at the region or at the district level, there needs to have a mechanism to bring relevant stakeholders so that they can have they can work together to bring better change, not only health, but improvements in education in other sectors as well. So, we have this type of approach, but most of the time the challenge is implementation. And I think this is one of the areas that we all learn going forward. Thank you.
Great. Thank you so much. There's a specific question for Dr. Arnab about diagnostic services, how that worked in the Indian system.
So the usual sort of structure is that the government primary health system has its own diagnostic services. So you would sort of refer to that. But particularly during COVID times, it became very apparent that the scale of requirement was so high that one has been essentially sort of co-opting. And so there's a fee for service model that's been working in many states, which works quite usefully in the form of providing services. But the private sector players often complain about delayed payments, essentially because of the way the government works, which is they have like quarterly payment cycles, whereas so these 90-day payment cycles often don't work for private providers. And so they're often pre-contracted at a price which often may be well below the rates at which the diagnostic services would be able to sell their services. So there is this, sense, particularly on the government side, which is that, look, there's a lot of spare capacity on the private medical services. We only want to use the capacity that's not going to be utilized, and we leave the market to sort of function in the other part where the private provider is charging fees. However, the private player often is very happy to work with the government because this is assured business. And so there is this tension between like, well, are we fully utilizing services of the private provider versus are we sort of undercutting the private client? And so, this is a somewhat confusing thing because this is not true only for primary healthcare. This is also true for, insurance. So it raises somewhat really problematic questions. So does the fact that you have more money in your bank account mean that you should be charged higher for the stent that's put into you? Clearly, that's really uncomfortable. But we're sort of already there in India at that point in time where we are saying, well, if you are from a poor family, then the price is much, much lower. Whereas if you're from a rich family, then you obviously pay much more. And so then the question is, so there are some perverse incentives that are sort of taking shape as we start exhausting full capacity of the private sector. But by and large, until we hit that limit, I think we've been doing really well. Private players are very happy to participate as long as there is capacity with them.
Great, thank you. Well, we have so many more questions coming into the chat, and unfortunately we're out of time, which I think is evidence of the quality of these presentations and also the engagement of our always wonderful community that we have in these webinars. So thank you everyone so much for your participation. These additional questions, some of them we're going to focus on in upcoming webinars, but please do continue to be in conversation with us about these issues and questions. A few themes that have come through all of these presentations are about the critical importance, not so much perhaps, insurance is very important and a complex piece, as we've heard many times, but also the critical importance of making sure human resources are well supported, especially frontline workers and community health workers, and also the importance of making sure that the systems themselves have the materials, supplies that those frontline workers need, that those are sort of the critical pieces, is what we've heard from all of our panelists. And that the rest of it is also very important and very complex, but that only follows once those critical pieces are in place. We've also heard a lot about the need for the very complex work of coordinating coverage and care across sectors, getting other sectors of the government involved, from transportation, of course, critical, to financing. All these different sectors are really key. As well as thinking about how to engage the private sector and international actors, getting everyone sort of on board with their different motivations and incentives toward this common goal of UHC. So some really interesting ideas on how to do that there. I want to give a huge thanks to our panelists, Of course, to IPHCE, to Dr. Abnet, and everyone on the team who's putting together these webinars. Really appreciate that. And of course, the participants in these webinars, we really benefit from your thoughts and your conversations. So thanks so much to everyone. Be on the lookout for our upcoming webinars as well. And thanks again to our panelists. Really appreciate your time and your thoughts. And I hope everyone has a lovely evening.
Thank you very much.
Thank
Thanks.
you.
Bye-bye.
Have a great day. Bye-bye.
Thank you. Bye.